हाँ लो शुरू कर दो लाइक
ओके सर, लाइव कर दिए 1 मिनट में सर।
तो जस्ट लेट अस नो व्हेन टू स्टार्ट ओके
हाँ
सौरभ
सर। हाँ सर।
if it's live just let us know.
ओके सर।
वीडियो शेयर करना है क्या?
Which one Rajni?
No, this I'm not able to make it as a thumbnail, sir, for the video.
सर हम
But
लोग
it's
लाइव हो गए देखो सर।
No, I didn't understand your question.
fine, sir. No, the videos, then it's just obstructing my slides, sir. So not able to make. Now I made it as a thumbnail. That's okay, sir. Got it.
Okay.
Drag it
Okay.
down, drag your video down.
सर वी आर लाइव सर।
Rajni, you can start.
Good morning, all. Today I'll be talking about febrile neutropenia, management and its challenges. Coming to the definition, neutropenia is defined as a decrease in the absolute neutrophil count less than 1,000 cells. Absolute neutrophil count is not the same as the TLC. So one should always calculate the absolute neutrophil count from the total leukocytes count, which is multiplied with the percentage of the PMNs and the band forms divided by the 100. So always we have to look at the CBP differential count and the peripheral smear, because sometimes we may see on the CBP count as 1500 or 2000, but we have to look if there are any blast cells, and we should calculate the absolute neutrophil count. Only when it is less than 1000, we should call it as a neutropenia. Severe neutropenia is defined as decrease in absolute neutrophil count less than 500 or is expected to decrease to less than 500 in the next 48 hours. Profound neutropenia when the ANC is less than 100 cells per microliter. Febrile neutropenia is defined when there is an oral temperature greater than 101 or the temperature is greater than 100.4 on 2 readings during a 2 hours period and the ANC is less than 500 cells. Prolonged neutropenia when the neutropenia lasts for more than 7 days. We call it as a persistent neutropenic fever syndrome when there's no defervescence despite the treatment with the antimicrobial therapies for 5 days and with neutropenia. Recrudescent neutropenic fever when there is a initial defervescence followed by recurrence of fever even during the course of broad spectrum antibacterial therapy. So the different causes of neutropenia, there are congenital and acquired causes. The congenital being the Duffy neutrophil count and the familial neutropenia, congenital neutropenia. The acquired causes is because of the infections, various infections with the virus like hepatitis, human immunodeficiency virus, and Epstein-Barr virus. The bacteria, parasitic, and rickettsial can also cause neutropenia. Nutritional deficiencies, especially the vitamin B12, folate, and copper, typically causes neutropenia in association with other cytopenias. Rheumatological disorders like rheumatoid arthritis, SLE, and other rheumatologic may be associated with the neutropenia. The other causes being autoimmune neutropenia, aplastic anemia, and chronic idiopathic neutropenia. The most common cause of the hematological malignancies like leukemias, lymphoproliferative disorders, hairy cell leukemias, and myelodysplastic syndromes. Not to forget the medication, and the most common being the cytotoxic and immunosuppressive agents, which causes the neutropenia. Even some anti-cancer drugs like rituximab and tyrosine kinase inhibitors, which are not considered to be myelosuppressive, can occasionally associated with the isolated neutropenias. Not only the cytotoxic and immunosuppressants, there are some medications which can also be associated with severe idiosyncratic isolated neutropenia. These medications are the antithyroid medications like methimazole, carbimazole, anti-inflammatory drugs like sulfasalazine, NSAIDs, methotrexate, penicillamine, psychotropic drugs like TCAs, GI drugs like H2 blockers, cardiovascular drugs like ticlopidine and ACE inhibitors, dermatological drugs like dapsone, and some of the common antibiotics that we use in the ICU like macrolides, trimethoprim, sulfamethoxazole, semisynthetic penicillins, and vancomycins. Antimalarials like chloroquine, antifungals, antivirus, anti-seizure medications, these are also known to cause high granulocytosis and neutropenias. So I'll be discussing mostly about febrile neutropenia and the malignancy. So why is it so important? Because infections represent an important cause of morbidity and mortality in patients with malignancies. The mortality increases up to 10 times in those with malignancies than those without malignancies. The rate of major complications like hypertension and other organ failures varies between 25 and 40%, with the mortality rate of up to 11%. In case of sepsis and septic shock, the hospital mortality can increase up to 50%. Febrile neutropenia occurs in up to 80% of patients with hematological malignancies and 10 to 50% of patients with solid tumors receiving chemotherapy. There's a clear relationship between the severity of neutropenia and the intensity of chemotherapy. Basing on this intensity, different regimens are classified basing on the percentage of febrile neutropenia they cause. They're considered as high risk if they produce 20% of them produce febrile neutropenia, intermediate risk if 10 to 20%, and low risk if less than 10% of chances of febrile neutropenia. Age plays a major role with the worse mortality and morbidity. With increasing age, the mortality and morbidity increases. And along with the age, the other factors which increases the mortality and morbidity are the advanced disease, history of prior febrile neutropenia. If there's no antibiotic prophylaxis or granulocyte colony stimulating factor was given, the presence of mucositis, poor performance status, and if there is a cardiovascular disease. In case of febrile neutropenia, prognosis is worse in patients with coenbacteremia with mortality rates of 18% in gram-negative and 5% in gram-positive anemia. So once the patient comes with a febrile neutropenia, we have to do the risk assessment, and there are multiple validated scores which are available like Talcott, MASC score, and Cisne score. The most commonly used the MASC and the Cisne score. The MASC score is used to differentiate the patient who are at high or low risk for severe complications and mortality, and also to initiate a less expensive spectrum empiric antimicrobial schemes, especially whether to give oral or outpatient treatment in a low risk patients. The Cisne score is validated for predicting severe complications in febrile neutropenia with high risk scores greater than or equal to 3. The limitation of Cisne score is that the validation is only for solid tumors who are normotensive and stable. So this is the MASC score and the Cisne score. MASC score is considered as high risk if the score is less than 21 and low risk if it is greater than 21, greater than or equal to 21. And Cisne score, it's divided into low risk, intermediate risk, and high risk basing on the score. Low risk if it is a 0 points, and intermediate risk if it is 1 to 2 points, and high risk if it is greater than or equal to 3 points. So the MASC score is dependent on the burden of the illness, whether there is a mild or moderate or severe symptoms, whether there is a presence of hypertension or not, whether there is a chronic obstructive pulmonary disease, whether the patient has a solid tumor lymphoma with no previous fungal infection, presence of dehydration, no dehydration, outpatient status, and age less than 60 years. The variables for the Cisne score is the performance status greater than or equal to 2, presence of COPD or chronic cardiovascular disease, and presence of mucositis of greater than or equal to 2, monocytes less than 200, and stress-induced hyperglycemia. So once a patient comes with a oral temperature greater than 100, 38.3 or 101, 100.4 on two different occasions, then with a ANC less than 500, we should do the prompt assessment and calculate the MASC score. So basing on the score, if it is greater than 21, it is low risk. We can either start them inpatient broad spectrum intravenous antibacterial therapy or inpatient oral antibacterial therapy, or we can also consider outpatient in some patients. High risk if it is less than 21, and definitely they need inpatient broad spectrum intravenous antibacterial therapy. So after the risk scoring, we should do the initial assessment and investigations. Detailed history should be taken, including nature of the chemotherapy given. This is the most important thing. What is the chemotherapy given? Prior prophylactic antibiotics, concomitant steroid use, recent surgical procedures, and the presence of allergies. An initial assessment of circulatory and respiratory function should be done, and the vigorous resuscitation where necessary, like the ABC, should be done if the patient is very sick. And if a patient is in shock or there's a severe sepsis, then we should follow the sepsis bundle as per the sepsis guidelines. This should be followed by careful examination for potential foci of infection. We should remember that all neutropenic patients may not present with fever. They, especially those with those elderly patients, geriatric patients, and those who are on corticosteroids, they present with subtle symptoms like a confusional state. And we should be very vigilant when an elderly patient on chemotherapy presents with a confusional state. They may not present with the fever. So the urgent full blood count should be done, and we should ascertain the ANC along with other routine investigations like renal function test, liver function test, coagulation profile. If the patient has a respiratory illness or respiratory symptoms, then the chest X-ray should be done. Immediately, 2 sets of blood cultures must be taken. If the patient has a central catheter, then a blood culture, one from the central catheter and the other from the peripheral lines should be taken. So most of the chemotherapy patients, they may have chemo port. So we should look for the chemo port, which is generally missed. And if there's any suspected site of micro infection, then the cultures must be taken, like a wound swabs or any discharges or abscesses or perineal infections and all. They should be taken and investigated with the cultures. Urinary tract infection have to be suspected even in asymptomatic patients with a past history of such infections. So the conventional microbiology test require up to 24 hours for pathogen identification and further 24 to 48 hours for antibiotic susceptibility profiles. There are various rapid diagnostic testings and rapid antimicrobial susceptible testings that are available, which give results in a few hours. These are the matrix, that is matrix assisted laser desorption ionizing time of night. That's the MALDI-TOF, which can identify pathogens and can also be used to know the phenotypic resistant profiles such as beta-lactam resistance from positive blood cultures. Vitek2 is an automated system for identification in around 3 hours, 18 hours for susceptibility testing. Other automated systems using modified fluorescent in situ hybrid of the fish can can analyze bacterial growth rates and minimum inhibitory concentration values, which can provide results in 7 hours from positive blood cultures. These are all give reports only from the positive blood cultures. If there is any growth, your microbiology says there is a growth in the blood culture, and you do this test, then we can get the organisms. If there is no growth, then there's no this test cannot be performed. And coming to molecular biology, the rapid diagnosis directly from blood samples may provide faster results. Multiplex time PCR have shown high specificity with the sensitivity varying from 20 to 90%. The most common which are available in the market are the BCID-2 assays, which can identify up to 32 organisms, and also from the positive blood culture within an hour. And they also detect 10 resistant markers like MRSA, VRE, and several beta-lactamases like KPCs, IMP, OXA, NBM, and Vim carbaminases, and CTA-XM type of ESBLs. Many patients presenting with febrile neutropenia have respiratory viral illnesses, and respiratory panels help in identify organisms. Respiratory panels can also be done from the nasal swabs and oral swabs. If the patient is producing sputum, it can be isolated from those also. So the various viral illnesses like H1N1, influenza viruses, COVID-19, the enterovirus, rhino, and RSV viruses can also be detected through these respiratory panels. Several international guidelines recommended respiratory viral testing based on local epidemiology and prevalence. Etiologies of diarrhea in cancer patients are numerous and include infectious and non-infectious causes. Stool culture and other conventional tests only diagnose a small portion of GI illnesses. So in such scenarios, we can do GI PCR panels, and they have demonstrated significantly improved pathogen identification, include C. difficile. CNS panel for CNS infection, especially in patients with hematological disorders who can present it with meningitis. The biofilm film array ME PCR panel can diagnose bacterial and viral pathogens along with Cryptococcus neoformis and Cryptococcus gattii. Next generation sequencing has demonstrated improved pathogen detection in septic patients surpassing blood cultures. Molecular tests have potential to identify pathogens in patients with previous exposure to antibiotics also. But the major drawback is susceptibility testing. Identifying susceptibility patterns in gram-negative bacteria phenotypic resistance is not as easily predicted by available assays. Commercial array-based kits for extended spectrum beta-lactamase and carbaminase detection from positive blood cultures demonstrated high accuracy. Fungal diagnostics, there are different biomarkers. Currently, there are Aspergillus galactomannan and 1,3-beta-glucan. The galactomannan assay is specific for invasive aspergillosis, whereas the beta-glucan can assay any pathogen which has 1,3-beta-2-glucan as a cell wall component, including Candida species, Aspergillus, Pneumocystis jirovecii, and other mycosis. T2 magnetic resistance T2 candida is an emergent diagnostic for invasive candidiasis. In a prospective trial, T2 candida demonstrated an 89% sensitivity for diagnosis of invasive candidiasis, but there is a limited guidance and evidence for implementation. Biomarkers, there are several biomarkers, the C-reactive protein and procalcitonin that are increased in bacterial sepsis, but these should not be used alone to decide the diagnosis of bacterial infection. Other biomarkers are proadrenomedulin. They might add some value to the diagnosis process to differentiate bacterial infection from a non-bacterial inflammatory response. The new therapies are in development like T-cell CARs and TIL, which emphasizes the importance of differentiating between the cytokine storm and the true bacterial infection in a subset of populations. So this is a snapshot of what are the things we had to do when the patient comes with a febrile neutropenia. We had to look for any indwelling catheters. We had to look for any foci of infection. Complete examination has to be done, including the perineal region, oropharynx, CNS, skin, and everything has to be examined. We should know what was the previous positive microbiology results by checking the clinical records. This is very important because most of them may have a organism previously, MDR resistant organism, which we have to take into consideration. Routine investigation, as we have discussed earlier, plant culture should be taken if required. If the patient is having a persistence of fever and there's a prolonged neutropenia, we have to do high resolution CT, if required bronchoalveolar lavage also to know the pathogen. So, basing on the underlying hematological condition, there's a risk of fever in some conditions. Like in high risk is seen in acute leukemia patients, lemtuzumab treatment, allogenic hemopoietic stem cell treatment, or GVHD treated with greater than 20 milligrams per day steroids or neutropenia greater than 10 days. Moderate risk is seen in autologous hemopoietic stem cell, chronic lymphocytic leukemia, lymphoma, multiple myeloma, neutropenia in 7 to 10 days, and purine analog therapy. Low risk is in solid tumors and neutropenia less than 7 days. So coming to the management, any patient who comes with fever seeking emergency medical care within 6 weeks of receiving chemotherapy, we should assume them having a bacterial infection and draw the samples, blood samples. And within 15 minutes of trial, we have to do the systemic examination to find out the foci of infection and to give the appropriate antibiotic as per the infectious foci. And within 1 hour, that is within 60 minutes, we have to administer the empirical antibiotics. Then after administering the antibiotics, we have to do the scoring, the mass scoring. If it is a high risk, that is the patient's mass score is less than 21, then it's the candidate for inpatient management. But if there's a low risk, then we have to do the CISNE score. If the CISNE score is greater than 2, definitely the patient is for inpatient management. If the CISNE score is 1 or 2, they can be considered for outpatient management, provided there is a proper logistic and psychosocial supports. The logistic being the patient should be within the 1 hour distance or within the 48 kilometers from the hospital, And he should be willing to comply with the medicines, and he should be willing to come for regular follow-ups and daily blood counts. And he should have access to the communication, transport, and there should be a 24-hour by 7 caretaker present for such patients. So such patients can be considered for outpatient management. Inappropriate antibiotic therapy in critically ill patients leads to higher mortality, increased duration of hospital stay, and risk of drug resistance. So patients with febrile neutropenia require rapid administration of empiric antibiotics within 1 hour. But the ultimate choice of antibiotics is based on the local factors, that is the hospital susceptibility patterns, and the patient factors being the previous hospital admission, previous antibiotic exposure, infection or colonization, and the past history. There are several guidelines for management. These are the NCCN, there's a National Comprehensive Cancer Network, ECIL4, which is the European Conference on Infection in Leukemia, and IDSA, and the ESMO, which is the European Society of Medical Oncology. So I'll be talking about the IDSA guidelines. IDSA in high risk recommends initial antibiotic monotherapy, including an anti-pseudomonas beta-lactam, that is cefepime, a carbapenem, that is meropenem, imipenem, and cilastatin, but piperacillin tazobactam. Other antimicrobials like aminoglycoside, fluoroquinolones, and/or vancomycin may be added to the initial regimen for management of complications like hypertension and pneumonia, or if antimicrobial resistance is suspected or proven. Initial treatment of vancomycin and other antibiotics, again, gram-positive cocci is not routinely advised as a standard treatment. Gram-positive coverage is indicated only in patients with a suspicious of catheter-related infection, skin or soft tissue infection, pneumonia, or there is a hemodynamic instability, or there is an antibiotic resistance. Modifications to initial empirical therapy may be considered for patients at risk for infection with the following antibiotic organisms, particularly if the patient's condition is unstable or if the patient has a positive culture result suspicious for resistant bacteria. Like for MRSA, we can consider early addition of VANC or linezolid daptomycin. For VRE, early addition of linezolid daptomycin. For ES, we'll consider early use of carbapenem. For KPCs, we can consider early use of polymyxin cholesterol or tigecycline. In case of penicillin allergic patients with moderate hypersensitivity like hives and bronchospasms should be treated with a combination such as ciprofloxacin plus clindamycin or aztreonam plus vancomycin. Patients who are afebrile and develop signs and symptoms of infection should also be treated empirically with the same regimen as the high-risk patients. Recommended treatment for low-risk patients include combination of oral antibiotic therapy with ciprofloxacin and amoxicillin clavulanate. Other oral administered regimens commonly used in clinical practice are monotherapy with levofloxacin or ciprofloxacin and combination with ciprofloxacin or clindamycin. If the patient has been given a prophylaxis with the fluoroquinolones, then the fluoroquinolone cannot be used as an initial empirical therapy. Empirical antifungal therapy is not recommended for routine use in low-risk patients. Initiation of empiric antifungal therapy is recommended for patients who continue to have persistent fever of unidentified cause following 4 to 7 days of antibiotic treatment, or if the neutropenia is expected to last more than 7 days. In patients with febrile neutropenia who are already receiving anti-mode prophylaxis, then we should switch to a different class. There are special alternative therapies that we have to consider, especially for catheter-related infections. The blood must be cultured from both the catheter and periphery, and we have to measure the differential time to positive, which is the difference in time between the positivity of results between the catheter culture and the peripheral blood culture. A DTP greater than or equal to 2 hours is highly sensitive and specific indicator of catheter-related bacteremia. For CLABSI caused by Staph aureus, Pseudomonas aeruginosa, fungi, or mycobacteria, catheter removal is recommended in addition to systemic antimicrobial therapy for at least 14 days. Catheter removal is also indicated in tunnel infection or port pocket site infection, sepsis, septic thrombosis, endocarditis, and persistent bacteremia despite the 72 hours of therapy with appropriate antibiotics. For documented CLABSI caused by cons, staphylococci cons, the catheter may be retained using systemic therapy with or without antibiotic lock therapy. If there's a CLABSI, with some complications like septic thromboembolia or deep-seated infections or bacteremia, persistent bacteremia, then we have to consider treatment for up to 4 to 6 weeks. If pneumonia in an outpatient is diagnosed either on clinical grounds or on basis of radiological imaging, antibiotic cover should be extended to cover atypical organisms like Legionella and Mycoplasma by adding macrolide or fluoroquine to the beta-lactam antibiotic. Consideration for infection with Pneumocystis jirovecii should be given in patients who present with high respiratory rates and or desaturated readily off oxygen or on minimal exertion. Patients with AML during remission, induction chemotherapy, and those undergoing allogenic hemopoietic stem cell therapy and preconditioned chemotherapy are at risk of invasive fungal infections, especially aspergillosis. If invasive aspergillus is suspected, a high resolution CT should be carried out on the same time, looking for typical features such as nodules with halo or ground glass changes, and galactomatin should be measured in the serum. If vesicular lesions are suspected viral infection, then they should be treated with acyclovir after appropriate sampling. Ganciclovir or foscanate can be given if cytomegalovirus infection is suspected. If clinical or microbiological evidence of intra-abdominal pelvis sepsis is present, then we should add metronidazole, provided the patient is not on carbapenem or piperacillin tazobactam. Assessment for Clostridium difficile should be done, and it should be treated with oral vancomycin and metronidazole. So once we have started therapy, this is as per the ESMO guideline, we have to review the therapy at 48 hours. So if the patient is febrile and the counts have increased greater than 500, and if the patient is a low risk and the patient is on IV antibiotics, consider to switching to oral antibiotics. If on oral antibiotics, continue the same. But if the patient is high risk and the pathogen is not identified, discontinue aminoglycoside and continue IV therapy. If the pathogen has been identified, then consider specific antibacterial therapy. If even after 48 hours the pyrexia continues and the patient is stable, continue same therapy. But if the patient is deteriorating, seek expert advice from the ID physician or clinical microbiologist. Coming to the assessment, this is as per the IDSA guideline. They are suggested to reassess after 2 to 4 days. And after 2 to 4 days of empiric antibiotic therapy, if the patient is a low risk and there is an unexplained fever, and the patient is clinically unstable, if the patient is an outpatient, consider an inpatient. But if the patient is already IV antibiotics, modify antibiotics according to the culture results or infection site. And the antibiotic should be continued for 70 to 14 days or till the ANC increases greater than 500 count. If the patient has defervescence and the cultures are negative, continue oral or IV antibiotics until the ANC is greater than 500 cells and rising. If there's a documented infection, either if it's a low risk or high risk, modify antibiotics as per the culture. If the patient is responding, then continue for 17 to 14 days and till the ANC is greater than 500. But in case the patient is not responding, then what should we do? We have to examine and re-image. If required, CT, MRI should be done. Repeat cultures, biopsy, drain sites, if there is a worsening infection, assess for bacterial, viral, and fungal pathogen. Review antibiotic coverage for adequacy of dosing and spectrum, and consider adding empirical and antifungal therapy and broaden the antimicrobial coverage for hemodynamic instability. In high-risk patient, if there's unexplained fever and there's a persistent fever, clinically stable, there's no change in empiric antibiotics, just assess for the infection sites. But if the patient has deferred and the cultures are negative, continue till the ANC increases greater than 500. Again, we have to reassess again after 4 days. Then if there's a high-risk patient with prolonged fever that is greater than 4 days, then examine again, take the history, repeat the blood cultures, any suspected sites. If there is unexplained fever and clinically stable and the ANC is rising, there's a mild recovery is imminent, just observe and there's no antimicrobial change. But there is a clinically stable but mild recovery is not imminent. consider CT scan of sinuses and lungs. If the patient is already receiving fluconazole, you can start preemptive approach or empirical antifungal therapy and change to other class like echinocandins, voriconazole, or amphotericin B. If the patient is already receiving anti-mole prophylaxis, consider empirical antifungal, switch to other class. If the patient has a documented infection and clinically unstable, and there's a worsening signs of symptoms, so re-image, do CT, MRI, do repeat cultures, review antibiotic coverage, and consider adding empirical antifungal and broaden the antimicrobial spectrum. The duration of therapy is very important. Treatment is necessary until the patient is afebrile for at least 48 hours, clinically stable with resolution of neutropenia, that is, the ANC has increased greater than 500 cells and has negative blood cultures. Treatment with antibiotics can be discontinued if the ANC is less than 500 if the patient has been afebrile state for 5 to 7 days without any complications. High-risk patients that is such as those with acute leukemia and those who have recently had high-dose cytotoxic chemotherapy may require treatment with antibiotics for up to 10 days or until the resolution of neutropenia. Patients with persistent fever despite neutrophil recovery should be assessed by an ID physician or clinical microbiologist, and antifungal therapy should be considered. So this is the duration based on the site of infection. The skin and soft tissue, we can consider up to 7 to 14 days. In bloodstream infection, it is gram-negative, 10 to 14 days, gram-positive, 7 to 14 days. If it is by Staph aureus, 4 weeks from the first negative blood culture is greater than or equal to 2 weeks after the first negative blood culture. In bacterial sinusitis, it is 7 to 14 days. In bacterial pneumonia, 7 to 14 days. The fungal, mold, and yeast are considered invasive candidiasis, minimum of 2 weeks of the first negative blood cultures. If it is an invasive aspergillosis, minimum of 6 to 12 weeks. This is a chart which shows the guidelines by different societies. We have NCCN guidelines, ESMO guidelines, IDSA, and ECL guidelines. So the latest being the NCCN, which is 2022, but the ESMO and IDSA and ECL were way back in 2016 and 2011. ECL for the more or less similar recommendation, except ECL for which has a de-escalation escalation approach, and I won't be detailing about it. So coming to the NCCN, the major difference what we find is in the empiric gram-positive coverage, where the NCCN recommends skin gram-positive, empiric gram-positive coverage in skin and soft tissue infections, vascular access infection, no response within 48 hours of initiating gram-negative therapy, and pneumonia with MRSA suspected, and disseminated papules or other lesions. And the difference what we find is the empiric fungal coverage. As per the NCCN 2022 guidelines, they suggest to go for empiric fungal coverage if there's a necrotizing ulceration, there's a thrust, retrosternal burning or dysphagia, suspected sinus, nasal infection with suspicious CT or MRI findings, pneumonia mold suspected, disseminated papules or other lesions, and fever continued greater than 4 days of empiric antibiotics therapy. Whereas ESMO and IDSA, they consider empirical antibiotics only if there is a patient is not responding after 3 to 7 days of appropriate antibiotic therapy. The other difference is the empirical viral coverage, where the NCCN recommends empirical viral coverage in case of necrotizing ulcerations, vesicular lesions, retrosternal burning or dysphagia, or encephalitis. ESMO recommends empirical viral coverage in case of encephalitis, but IDSA recommends if there is only a documented or clinical evidence of viral infection. Empiric anaerobic coverage in case of necrotizing ulceration or suspected abdominal source or suspected perirectal source as per the NCCN guidelines. ESMO as per the suspected abdominal source, and IDSA recommends only if the patient is hemodynamically unstable for initial doses with the standard agents. De-escalation as per the NCCN is to be based on the neutrophil recovery, rapidity of effervescence, site of infection, infecting pathogen, and the patient's underlying illness. But as per the ESMO and IDSA, we should treat with the appropriate specific therapy. The duration of empiric therapy, if there, as per the NCCN, if there is a documented infection, for SSTF 5 to 14 days, but for BSS 7 to 14 days. If it is fever of unknown origin, we have to continue till the ANC is greater than 500 cells and recovery, or can consider these options if ANC is less than 500, discontinue therapy or de-escalate to prophylaxis or continue current regimen until neutropenia resolves. Whereas ESMO and IDSA recommends to continue till the ANC is greater than 500 and has been afebrile and asymptomatic for 48 hours, and there are no presence of complications. Prophylaxis. When should we give prophylaxis in a patient receiving chemotherapy? So we should consider fluoroquinolone as an initial treatment for patients who are considered high risk for febrile neutropenia and who are expected to have extended period of profound neutropenia, that is ANC less than 100, lasting longer than 7 days as prophylaxis. Both ciprofloxacin and levofloxacin are recommended to treat patients at high risk for febrile neutropenia. Levofloxacin is the preferred agent if streptococcus-mediated neuromucositis is suspected. Patients who are considered high risk for invasive fungal infection, such as candidiasis from allogenic hemopoietic stem cell transplant or from intensive remission induction or salvage induction chemotherapy for acute leukemia, should be considered with the prophylaxis with antifungals. They can be initiated with antifungals like fluconazole, itraconazole, voriconazole, posaconazole, micafungin, or cascofungin. Prophylaxis against invasive aspergillus infection with posaconazole should be considered for selected patients greater than 13 years of age who are undergoing intensive chemotherapy for acute myeloid leukemia or myelodysplastic syndrome. Prophylaxis against aspergillus infection in pre-engraftment allogenic or autologous transplant recipients is recommended in patients with prior invasive aspergillosis or anticipated prolonged neutropenic period greater than of at least 2 weeks, or prolonged period of neutropenia immediately prior to hemopoietic stem cell transplant. Antifungal prophylaxis is not recommended for low-risk patients in whom anticipated duration of neutropenia is less than 7 days. So coming to the prophylaxis with the granulocyte colony stimulating factor, there are different granulocytes in the market like filgrastim, SND, or pegfilgrastim, which is a pegylated filgrastim. So the treatment with the GCS reduces the time to neutrophil recovery and decreases the duration of febrile neutropenia. The NCCN recommends that patients with solid and non-myeloid malignancies are evaluated for risk factors of chemotherapy-induced febrile neutropenia prior to first cycle of therapy. The intensity of chemotherapy regimen administered is associated with the severity of neutropenia. So G-CSF prophylaxis should be administered in patients with high risk of febrile neutropenia, that is greater than 20%. In case of patients with low or intermediate risk, the decision to give G-CSF is to be considered taking into consideration the various other factors. These risk factors being the disease risk factors, basing on the type of chemotherapy that is given, the dose of chemotherapy, whether it is a high dose, dose dense, or standard dose, and whether that what is the treatment intent, whether it's a curative or palliative intent. In the patient risk factors that's to be considered is a prior chemotherapy or radiation therapy, persistent neutropenia, bone marrow involvement by the tumor, recent surgery or open wounds, liver dysfunction with bilirubin greater than 2, renal dysfunction with creatinine less than 50, age greater than 65 years, receiving full chemotherapy dose intensity, HIV infection, or poor performance status. So what are the challenges that we face while managing febrile neutropenia? As we all know, febrile neutropenia is a classic oncology emergency, requires sufficient clinical experience and in-depth knowledge of current guidelines, and there are multiple guidelines, and we are not sure of the every guideline recommend different things. So implementing guidelines in everyday practice may prove challenging. Individual risk assessment and judgment is of crucial importance, though there are various assessment scores which guide us, but they are not completely dependable. Patients needs reevaluation on a regular basis according to clinical presentation and diagnostic findings. A multidisciplinary approach is required as infections can drastically worsen the condition. The clinical challenges is marked by the challenge of identifying unusual pathogens. There are growing areas of diagnostic tools and rapid diagnostic tests like PCR-based tests, but cannot distinguish between the infection or disease from the colonization. GI PCR panels cannot detect strongyloids, tuberculosis, cytomegalosis, and certain strains of adenovirus. It does not rule out non-infectious etiologies like GVHD. Whereas CNS PCR cannot detect Toxoplasma gondii, molds, or JC virus, which are important hematological and hematopoietic stem cell transplant patients. These tests have not always had a clear positive impact on clinical outcomes and the antibiotic use. There's a misuse and overuse of diagnostics and have their own potential for untoward cost and overruns. Clinicians are also often hesitant to de-escalate therapy in patients with febrile neutropenia based on these tests. So the big question is the optimal utilization of these tests. The second one being the extended broad spectrum antimicrobial therapy. Antimicrobial de-escalation in febrile neutropenia without a clear diagnosis more challenging. Antimicrobial triage is another major challenge to follow. There is a lot of resistance of clinicians to limit antibiotic use and the scarcity of literature on improving outcomes. 4 commonly used guidelines have variable recommendations for empiric therapy in these populations. There is no consensus has been reached for the duration of empiric antibiotics for clinically stable afebrile patients at high risk of prolonged neutropenia. And differentiating infection and non-infectious fever is another challenge. There are no effective biomarkers. Differentials for fever could be a drug fever, a GVHD, especially post hematopoietic stem cell transplant who present with diarrhea and fever, they can have a GVHD, which is difficult to differentiate from the infectious disease. Or and we should have high suspicions for HLH, which can also present as fever and cytopenias. And it is commonly missed, and we should have high suspicions for HLH, and we should do the test accordingly. And the other thing is the myeloid reconstitution syndrome, which is nothing like a inflammatory reconstitution kind of syndrome, which the patient presents with fever when there is a increasing counts. So they can also, when the patient is having increasing counts, they can also present with fever, and this can also they can malign the infections. Last but not the least is the patient education, which plays the important role. Providing patients with upfront and clear instruction on monitoring symptoms and body temperature and contacting the appropriate service when needed is the major roadblock that we face. A brief discussion on management of adults with non-chemotherapy induced neutropenia. Patients with non-chemotherapy induced neutropenia have variable risks of infection ranging from life-threatening sepsis to chronic infection or no significant infections. Risk for infection is influenced by bone marrow neutrophil reserve, severity of neutropenia in patients with inadequate bone marrow neutrophil production, and associated immunodeficiencies. Neutrophil reserve can be assessed by the bone marrow aspirator biopsy, but every time we cannot do bone marrow aspirator biopsy. So the other way to assess neutrophil reserve is the presence of pus, splenomegaly, ESR, C-reactive, and monocyte count, which can help in predicting the bone marrow reserve. If there's an adequate bone marrow reserve, then we should treat like a general population, except for patients with severe chronic idiopathic neutropenia, that is ANC less than 500, for whom we have to give G-CSF for acute infections. If there's inadequate bone marrow neutrophil reserve, we should treat in the same way as we treat febrile neutropenia and malignancy, and we should treat with the broad spectrum antibacterial therapy covering gram-positive and gram-negative organisms. Regarding granulocyte transfusion, there is no proper recommendation or guidelines for a granulocyte transfusion. But several lines of evidence have showed a trend towards greater efficacy of granulocyte transfusion, but no trial has established a unequivocal benefit. So granulocyte transfusion can be given in patients with absolute neutrophil count less than 500 cells, except in the case of chronic granulomatous disease, if there is evidence of bacterial or fungal infection, and there is unresponsiveness to antimicrobial treatment for at least 48 hours, except in extreme circumstances with life-threatening infection. There is likelihood of bone marrow recovery or plan for potentially curative therapy, and this should be given in neutropenia induced by chemotherapy or hematopoietic stem cell therapy. Thank you.
Thank you, Rajni. I think we have a very comprehensive review of an important problem, that is the approach of a patient with febrile neutropenia. Importantly, what we should remember is with increasing availability of definitive therapeutic options for quite a few malignancies, the population of these patients is only going to go up. So when we look at the patient with febrile neutropenia, a priori, we need to differentiate whether this is a cancer-related febrile neutropenia or a non-chemotherapy related uh, uh, febrile neutropenia, because the scoring systems, the severity index, and the risk stratification of these patients is different. If there is a patient with a chemotherapy in the history, then the mask scoring index should be your default scoring system, which you will apply for these patients. On the other hand, if it is a non-malignancy related febrile neutropenia, you apply the clinical index of stable febrile neutropenia score for these patients. The difference is these chronic diseases like COPD, chronic cardiovascular disease, um, hyperglycemia, they are very strong with non-cancer. They don't play a big role in the cancer-related febrile neutropenia. Second point we need to remember is that non-infectious causes of febrile neutropenia are often overlooked and underdiagnosed. Classical example is for example, a patient with prophylactic can have fever as well as prophylactic can produce neutropenia. So we should not approach this patient in the classical way as we approach a patient with an infective etiology of febrile neutropenia or febrile neutropenia with infection prophylaxis. Some of the antibiotics which are used for the treatment, which are used in such patients, especially vancomycin. Maybe in some patients with immunocompromised state, trimethoprim sulfamethoxazole. Some of the anti-inflammatory drugs like methotrexate. Some of the psychotropic drugs like tricyclic antidepressants. Some of the cardiovascular drugs, mainly ACE inhibitors, digoxin, they all can cause neutropenia, and seizure disordering anti-epileptic drugs like carbamazepine and phenytoin can also produce fever with neutropenia. So, and these drugs are sometimes co-prescribed in patients with this disorder. So, what is causing the disorder? What is the result of the disorder? And what is a coexistent phenomenon? We need to be very clear. But as Rajni has said, a structured approach, a good history, a detailed physical examination, and an algorithmic approach can usually give the cause of the fever and neutropenia in these patients, and our eyes and ears should be open for all possibilities for these complex patients. Ghanshyam?
I think febrile neutropenias are one of the most challenging scenarios that one can face in intensive care, especially if you are a unit which doesn't routinely see such patients or which routinely does not look at oncology patients. The reason being, many a time you may not have the necessary infrastructure, especially the isolation precautions, which become extremely important when you're managing these patients. Your nurses, with respect to the absolute aseptic precautions which are needed while managing patients with febrile neutropenia. And I think this is one subset of patients where probably your threshold for imaging and investigations should be on the lower side. Those are a couple of things which I think you should keep in mind.
Thank you all for joining us today. If you have any queries or comments or clarifications on the topic presented, please do post them on the group from where you got the link from, and we will answer them in the shortest possible time. Please do join us for the Journal Club later this month on post-ICU care of patients. It will be an interesting Journal Club as well. Please subscribe to the YouTube channel for more information. Thank you all and have a good day. And be safe in the rains. It is pouring and pouring in.
Thank you. Thank you all.
Thank you, sir. Thank you.